I would like to welcome you to the BACCH and BACAPH Improving Services series known as the B-BISS program. The B-BISS program is a series of PowerPoint presentations with accompanying theoretical papers which introduce the thinking behind the NHS long-term plan, intended for community paediatricians and child public health experts to enable them to implement the NHS long-term plan successfully. In the longer term, it is hoped to collect and share best practice to facilitate improving service outcomes. This first module of the series introduces the NHS long-term plan and provides an overview of where community child health services are now and proposes some ideas on how BACCH and BACAPH might support you to improve the services that you deliver in the light of the plan. BACCH, at a council meeting in December 2018, has in many ways preempted many of the themes contained within the NHS long-term plan. The business plan included improving outcomes based on pathways and networks and how to measure and improve their impact, improving commissioning to provide information to commissioners about how services should look and the workforce they require, improving leadership by developing skills and networks to support clinical leaders, and improving continued professional development. More detail is available on the BACCH website. The Improving Services series combines many of these elements into one package, and it is hoped that local community paediatricians or perhaps learning sets will take them forward. We are also very keen that the most effective developments are shared within the organisation to encourage all aspects of quality improvement. In this introductory module, the content and learning objectives are as follows. To start with, a very short history of community child health services over the last decade, followed by an outline of current concerns. Then an introduction to the NHS long-term plan, and lastly an outline of the modules of the BACCH and BACAPH Improving Services series. Undoubtedly, the last decade has been the most difficult during my professional career. 2008 saw the global economic collapse followed by a period of profound economic austerity, with effectively a 20% reduction of NHS budgets over a 5-year period and even greater cuts to local authority services in England. The Health and Social Care Act heralded a profound change within the NHS, attempting to introduce a market economy to drive down costs and increase efficiency. We all know that a free market economy is not appropriate for healthcare. Just ask any health economist what discount rate they use for health benefits. The overall result has been increasing inequity, fragmented services and a focus on activity rather than outcomes. Alongside these changes has been a change in morbidity and increasing demands on the NHS, particularly for mental health issues, obesity and ASD. And now we have to live with the long shadow of COVID. There have been a plethora of reports over the last decade, but not all have had a great impact. They are essential reading for clinical leaders, but I'm not going to attempt to summarise them now, but rather I will use the best elements when describing how to implement the NHS long-term plan. For those of you who were not around at the time of the NSF, it stands for National Service Framework, and ECM stands for Every Child Matters, and COE, Council of Europe. It's certainly worth reading the executive summaries of these reports, and particularly the Don Berwick report, A Promise to Learn. During the 2019 BACCH ASM, we asked members what their predominant concerns were in relationship to delivering high-quality services, and this is the summarised list. Recruitment was the biggest issue. Many departments were finding it difficult to recruit, both at consultant and non-consultant grades. Individuals recognised the changing morbidity presenting to community child health services and the need for additional training for topics such as mental health and NHS management in the new world of integrated care services or integrated health systems. A few paediatricians recognised the need for more thinking time as well as clinical time in their working lives. This was particularly true for those in leadership roles. Many departments are under pressure to demonstrate their value to commissioners, but without universal benchmarks or comparable measures, this was proving a real challenge. A few recognised that there was too much variation in both service design and outcomes. Some complained that there was a mismatch between resources and their current clinical workload, often perceived as being due to commissioners not understanding their work in community child health departments. Many of these member concerns were replicated in the report from RCPCH reviewing 4 years of invited review unit work. Admittedly, the invited reviews were generally requested by either failing services or those threatened with or undergoing reorganisation. So we are not saying the concerns are universal, but merely they are consistent with member concerns. Many departments felt lost within larger organisations, did not feel their service had the respect or resources required, which in turn led to clinical disengagement with management and often clinical overload. Poor information is a handicap that many departments were working under, together with the difficulties in recruitment. Okay, so that's enough looking backward. Important though it is to learn from the past, now let's look forward. We will probably look back at 2020 and the COVID pandemic as a significant world event, like the economic crash of 2008. However, large societal shocks can also precipitate new ways of thinking. For example, the First World War heralded the emancipation of women and their right to vote. The Second World War heralded the Universal Declaration of Human Rights and the beginnings of the NHS. Can the COVID-19 pandemic be the tipping point, a once-in-a-generation transformation to a world economy that values people and the planet more than mere profit? The other major event was the publication of the NHS delivering net zero on the 1st of October, which signals the NHS seeing climate change as a health issue and committing the NHS to become net zero by 2040. The NHS plan signals a major change in direction, away from resource distribution based on a free market to a more managed system with a relentless focus on prevention and quality improvement. This is a very welcome change from the competition and short-term efficiency-orientated targets of the Lansley reforms. The plan puts patients at the centre and clinicians in key roles as accountable leaders responsible for service development, delivery and improvement. This will require a new set of skills, both working within integrated health systems and also new competencies for population health management. BACCH is therefore developing a series of mini-modules to fill this gap. I have distilled the NHS long-term plan down to 8 bullet points over 2 slides that reflect the major system changes that are required to improve outcomes. Central to future plans is the redesign of care based on pathways, guaranteeing that all the parts will be in place and working well together, linked to a system of quality improvement that enables continuous positive evolution. Ensuring all the parts are in place will require close working relationships with all the other parts of the NHS and with other multiple agencies, effectively an integration agenda. To achieve this will require skillful leadership and management in the new integrated health systems. The enormity of this task should not be underestimated. The NHS plan recognises the importance of prevention and has a particular focus on secondary prevention, meaning the best management of conditions and the prevention of comorbidities for groups of individuals with a particular disease or condition. This links into population health management, which we will cover later. It also involves thinking upstream to prevent problems presenting to the NHS and creating opportunities for better working relationships within networks for groups of patients and integration with local authority services and public health. The integration with primary care will depend on the many simultaneous changes happening within the reorganisation of primary care, and it's important to note that this is where some of the NHS investment monies are going. I'm now going to examine each bullet point in a little more detail, but more will be covered in depth in one of the later mini-modules. The term patient-focused has an extra dimension when working with children and young people, whose care and well-being is dependent on other family members, particularly their parents. This is particularly evident for vulnerable families with parents who may not have the necessary skills to ensure all the needs of their children are met all of the time. In a clinical setting, proactive prevention translates to anticipating future health needs and planning for them, so reducing or eliminating secondary comorbidities associated with the primary problem. This may require both individual and population, meaning groups of patient, approaches. All parts in place and working well together from a patient perspective is obvious, but often difficult to achieve in practice. What is vital is that in the new integrated health systems is the process of improvement based on both new evidence and also feedback from meaningful measures that represent what's important to both patients and clinicians and are the driver for continuous improvement. There will be a separate mini-module on the design and evaluation of care pathways. Although the NHS plan specifically mentions integration between primary and specialist care, between physical and mental health, and between services involving social care, the concept of integration is far more than this. It includes breaking down barriers between community, hospital and specialist care within the NHS, between health, education, social care and other agencies, as well as between different sectors, for example public, private and charitable sectors, essentially creating a strategic alignment and synergy between all of the parts. There is little mention of commissioning and regulation within the NHS plan, but clearly these two major components on either side of provision will need to be aligned with new ways of working, particularly care pathways. This agenda potentially allows more resource decisions about how care is delivered to be moved close to the front line of patient care. There will be a separate mini-module exploring the meaning of integration for children and family services. Personally, it took me a long time to realise the differences between leadership and management, and at the same time recognise both are essential for getting things done. The NHS plan expects clinicians to be service leaders, able to generate new ideas, convince others of their worth, motivate the practical process of improvement, and at the same time be accountable, attend to the details, support members of the team, and evaluate the benefits, which also means being good managers. We have separate mini-modules on leadership within integrated health systems to explore the competencies required. Chapter 2 of the NHS long-term plan, together with Advancing Our Health in the 2020s, both advocate greater attention to prevention. Although the importance of prevention is self-evident, these two documents are inconsistent in their approach. For example, the latter does not mention population health management even once. At the core of primary prevention is tackling the determinants that contribute to health and disease. It is also important to consider assets that promote health, as well as hazards that undermine health. The prevention mini-module examines how assets and hazards can be grouped together in terms of lifestyles and determinants when planning services. In this slide we have health outcomes on the top of the vertical axis. The contribution played by health behaviours, clinical care, social and economic factors and the physical environment are in the central columns with more detail in the right-hand column. Population health management starts with the recognition that clinical care only provides about 20% contribution to overall health outcomes judged by length and quality of life. Health behaviours, social and economic factors together with the physical environment contribute the remainder. These are all health determinants. The NHS long-term plan encourages clinicians to consider these determinants of health when making plans for patients to manage their condition. In the new integrated health systems, the intention is to start being able to tackle relevant health determinants as well as provide clinical care. This will all be covered in more detail in the Population Health Management mini-module. Much of the thinking behind the NHS long-term plan easily maps onto the 2014 BACCH family-friendly framework. You will remember that the family-friendly framework has a 4x4 approach. The basics of clinical care is covered by evidence, competence, place of delivery and timing. The essential elements of the pathway include prevention, recognition, assessment and a range of interventions. These then all come together in networks which provide the initial, review and transition phases of the whole pathway, linked together with the life course pathway. Finally, for any system to work, there has to be agreement on its common purpose, values derived from human rights that form the foundations of care, clear leadership, and the ability to learn from delivery as well as research. These are all covered in the service pathway. My personal opinion is that the key points contained within the NHS long-term plan are excellent and should move the NHS in the right direction. But that is not to say there will not be challenges along the way. Creating a set of shared values across different organisations, particularly those who've not worked closely together in the past, will probably be the first challenge. The integration of community services within primary care could or should possibly lead to the integration of primary care within community services. Devolving resource allocation to clinical networks will also be a challenge for some commissioners who seem to prefer micromanaging a service rather than letting those on the front line make the relevant decisions. Finally, integrating prevention within the NHS, all within integrated health systems when resources are limited and need to be allocated to elderly care services, will also be a challenge. Finally, the NHS has to become net zero. To take this agenda forward, we are in the process of developing what we call mini-mods, which are modules of learning that should take about 20 to 30 minutes of clinician time. It is hoped that each will be a PowerPoint presentation, a webinar, and possibly a podcast supported by a longer paper which covers the theory and practice behind the content. Obviously, this is going to take some time to develop, but we have the beginnings to share with you today and would very much appreciate your feedback so that we can check that where we are going is in the right direction and what we are offering is practical and relevant to you. We think the mini-mods are best tackled in the order within this table, but they are designed to be a mix and match economy. If anybody would like to contribute to the process, we would welcome to hear from you. We would appreciate hearing what your priorities are and whether a national, regional or local approach would be best. My guess would probably be a mixed economy. What will be important is to share your experience so others don't repeat what is less effective and quickly implement what does work. BACCH is your organisation and recognises that its main reason for existence is to help you develop and improve your services to enable all children to reach the maximum of their potential. Since the role of BACCH is largely one of sharing best practice in a digital age, we need to explore the best ways of doing this for you, whether this be moderated discussion groups, webinars, podcasts or just plain email. We would welcome feedback and further involvement. Please don't be shy coming forward.